All right, last week, Thursday to be exact, the American Medical Association released a 54-page document instructing, or more accurately, indoctrinating physicians on how to talk to their patients. The document tells physicians, quote unquote, commonly used language that is really just language that advances woke newspeak. It suggests so much new, misleading vocabulary that 40% of its total content is devoted to the glossary. The point, it says, is to reshape narratives in pursuit of health equity. According to the association, health equity and related fields, including, and it admits this, critical race theory, gender studies, disability studies, as well as scholarship from social medicine, gives us a foundation for an alternative narrative, one that challenges the status quo, end quote. So what are we to make of this? Joining me now to discuss this new document, this new guidance for medical personnel, is Dr. Jeff Barrows, Senior Vice President of Bioethics and Public Policy at the Christian Medical and Dental Association. Dr. Barrows, welcome back to Washington Watch.
Thank you, Tony. Good to be with you again.
So, Doc, let me ask you, what's your reaction to this latest AMA document?
Well, I wish I could say I'm surprised. The AMA is increasingly ideologic in all of their public statements. They clearly have bought into the LGBTQ agenda in so many ways, and now with this, they are clearly buying into critical race theory, and they're not hiding it. They're making it very clear. They're in fact very proud of it. So while not surprised, I'm very concerned because the AMA is now moving into, as you alluded to, the whole topic of how a physician or healthcare professional should begin to talk to their patients within the privacy of an examination room, and that's always very disconcerting.
Well, in some of the terms, as you look through, I've looked through this, the 54 pages. You know, avoid unintentional blaming. For instance, here is, instead of using this term, workers who do not use PPE, that's personal protective equipment, it should be people with limited access to specific services or resources, or workers under-resourced with, and name the specific service or resource. So it really is taking away personal responsibility. Also, when it goes into various health-related issues, it's removing the individual from responsibility, I guess placing it on all of society, which is really what critical race theory is about.
Yeah, I noticed that. And also another example is they are saying to healthcare professionals, rather than using the terminology people who do not seek health care, they ought to instead use workers under-resourced with a specific service or particular healthcare resource, which completely, as you said, takes away any type of personal responsibility. And that is not the way medicine is. In my many years of practice of OBGYN, I found that when someone was not seeking health care, there was a reason for it. Or when they were doing something that was not good for their healthcare, it was an individual decision. And this is the majority of what we're seeing in healthcare. So to shift it to somehow a systems view or a systems explanation for this is, number one, it's wrong. It isn't based on good evidence, and it's dangerous.
Yeah, dangerous. I would like to zero in on that because we've seen this in other industries or aspects of society. I'll say the Department of Defense, for one, where their mission is to fight and win wars. Doctors are to treat patients and help people get better. But there's a distraction that takes place. There's only so much time. My doctor is a friend of mine, and I know how much he has to do in keeping up just with the paperwork and all of the demands. This is yet something else that can distract from the core mission, is it not?
Well, I agree. The core mission is to really, I think, treat the individual as an individual. And this is another problem with this whole approach, is that they want to move away from looking at individuals as individuals and looking at them as part of a structural system. And that's where the problems are. And as a patient myself, I want to be looked at as an individual. I want my physician to be caring for me and my particular needs, my particular health concerns at that time. And that's all critical within that physician patient relationship that I was raised and trained to value so much.
How do you think doctors are going to respond to this? And I know a lot of these things are kind of long term. They want to get the students coming out of medical schools. That's where they'll use their greatest amount of influence. Yes. Well, the older doctors just kind of blow this off, but it's going to be more of the indoctrination of the younger doctors.
It will initially be a kind of recommendation, and as you said, certainly an indoctrination that will no doubt begin in medical school. Most of the medical schools now incorporate certain interactions within the examination room with paid actors, and no doubt the scripts will be provided for the students and they will be indoctrinated into what language to use. But my long-term concern as well is that while now it is a recommended terminology, that eventually it will become a demanded terminology. And we're already beginning to see this with the LGBTQ issues, and that if you do not use the right language, you do not use the right phraseology, you don't use the right narrative, then you can lose your job.
Right, wrong pronoun, whatever. Dr. Barrows, always great to talk with you. Thanks so much for joining us today.
Well, my pleasure, Tony. Great to be with you.